So we have two doctors that will present on this subject. We have Dr. Amanda Black, who is here, and Dr. David Archer, who's on the phone because he is from the US and he couldn't make it this morning. They had trouble with the planes. And anyway, so he'll be doing his session anyway, but through the speakers. Dr. Black received her medical degree from the University of Western Ontario and completed her OBGYN residency at the University of Ottawa. She completed a fellowship in contraception and pediatric gynecology at Queen's University and a master's of public health at Johns Hopkins University. She's currently an associate professor in obstetrics and gynecology at the University of Ottawa and works at the Ottawa Hospital and the Children's Hospital of Eastern Ontario. Currently, she's chair of the SOGC's National Contraceptive Awareness Program and the Canadian Contraception Consensus Committee. She is passionate about ensuring that all Canadian women, including adolescents, have access to a wide range of affordable contraceptive options and continually advocates for this at the provincial and national level. And Dr. Black, Dr. Archer, David Archer, he's director of Conrad Clinical Research Center, the Jones Institute for Reproductive Medicine, and professor of obstetrics and gynecology at the Eastern Virginia Medical School in Norfolk, Virginia. He received his MD from the University of Louisville School of Medicine. He completed his residency in obstetrics and gynecology at the Louisville General Hospital. Dr. Archer was a National Institute of Health NIH postdoctoral fellow in reproductive endocrinology at the University of Pennsylvania School of Medicine and the special NIH postdoctoral at the Hormone Laboratoriet of the Karolinska Hospital in Stockholm, Sweden. He published extensively on contraception and menopause, and his current research is in the mechanism related to endometrial bleeding. So please welcome our two presenters. Well, one that's there. And
So thank you very much for the kind introduction, for inviting me to come and speak today, and to all of you for showing up for an 8 o'clock in the morning session. Before I start, as Dr. Gagnon said, I am from the University of Ottawa, and as many of you may have heard, we lost a dear friend and colleague a couple of days ago after a very long and courageous battle. So before I start, I'd just like to pay tribute to Dr. Andrée Gruslin. So although she can't be with us here today, we'll know she's always with us in our heart, encouraging us to be our best and reminding us that even in the face of adversity, there's insurmountable things that we can always overcome. So I'd like to go on and talk about how low can you go and what exactly is happening with the evolution of combined oral contraceptive pills. So just a quick slide on disclosures. I have had some affiliations with the following companies over the last 2 years. That includes Abbott, Actavis, Bayer, Merck, and Pfizer. So the objectives of this morning's session are, first off, to discuss the global and the Canadian contraceptive landscape. So what's happening both at a global level as far as what's being used for contraception, as well as what we're doing in Canada. And then highlight some of the key considerations and goals of treatments when choosing oral contraceptive pills for contraception. Identify potential barriers to contraceptive use and adherence, and discuss ways in which we can promote contraceptive use and avoid discontinuation of the method of contraception. And lastly, to discuss the evolution of the oral contraceptive pill and potential implications for patient care. So first off, if we look globally at what's being done in the area of contraception, we actually find from a United Nations report that overall the mix of contraceptive methods hasn't really changed that much over the last 20 years, so between 1990 and 2011. And female sterilization and intrauterine contraceptive devices were the two most common methods in both 1990 and 2011. The oral contraceptive pill actually has the widest geographic distribution of any of the methods. And what's interesting, in almost all countries, most contraceptive use is comprised of just really one or two dominant methods. And those dominant methods include the pill in 20 countries and more traditional methods in 11 countries. So this is the data from the United Nations that looks at contraceptive prevalence by method and by region in married or women in a relationship between the ages of 15 to 49. And again, this just highlights the fact that overall the mix of contraceptive methods hasn't really changed between 1990 and 2011. So if we look here, we have seen an increase in contraceptive prevalence, but we haven't necessarily seen a huge change in the mix of methods. And female sterilization and IUDs were really the two most common methods. But when you look at oral contraceptive pills, which are here, they have the widest geographic distribution of any of the methods of contraception. And what's interesting is the method-specific prevalence really varies widely across the regions, but there's few changes from 1990, again, in the kinds of methods used. In almost all countries, most contraceptive use, again, is comprised of just one or two methods. And in fact, in 1 in 4 countries, a single method accounts for more than 50% of contraceptive use. And this imbalance in the mix of methods may actually signal deficiencies in the access to a full range of contraceptive options for women in all of these different countries. Specifically, when we look at the oral contraceptive pill from a global perspective, we see that it represents 8.8% of contraceptive prevalence throughout the world, and that's higher in developed countries, more along the lines of 15.4%. And in fact, more than 100 million women worldwide use an oral contraceptive pill, so it's used by millions of women throughout the world. Again, 61% of couples worldwide use a method of contraception, and 9 out of 10 of these use a modern method of contraception. However, 50% of women or couples don't have access to modern contraceptive methods, even though they would like to use contraception. And what does this mean? Well, unfortunately, this can result in unintended pregnancies. And in a worldwide study that was conducted between 1995 and 2000, they found that 25% of pregnancies were unintended. And in another study in 2008 estimated this could actually be as high as 49%. And up to 40% of unintended pregnancies will be terminated. Specifically in the United States, if you look at our neighbors across the border, they report that up to 50%, almost 50% of pregnancies are unintended. And many of those occur in the face of users of contraception. So people are using contraception but are still having an unintended pregnancy. And the problem with that is it affects women of all ages, marital status, and ethnicities, and it occurs in both developed and developing countries, but the ones who are affected to the greater degree are the poorest women and those living in developing countries where maternal morbidity and mortality are high. So that's a global view of things. So what's actually being done in Canada, and what are Canadian women using? And what we found on the last published Canadian contraception survey is that the most commonly used method of contraception in Canada are condoms and the oral contraceptive pills. So again, we have 1 or 2 methods that really dominate the contraceptive landscape. And this hasn't changed significantly from previous studies that have been performed. And again, in 2010, we found that there was a similar prevalence of contraceptive use in Canada. What is interesting is that the consistency of contraceptive use in Canada isn't as high as we would like it to be. Certainly, although 65% of women who are sexually active and not trying to conceive are always using a method of contraception, that means on the flip side, 35% of women who are sexually active and not trying to conceive are either not using a method of contraception at all, or they're using that method of contraception inconsistently. And the thing is about contraception is women are going to require contraception for at least 30 years of their life. They have different contraceptive needs at different stages of their reproductive lives. So what might be suitable for an adolescent may not be necessarily suitable for a 42-year-old woman with hypertension, and therefore we have to individualize their contraception according to their needs. The other thing that we have to remember is that they have, these methods have benefits that go beyond contraception, and it's something that we need to consider when we're counseling our patients and looking for what the best possible contraceptive option would be for them. Unfortunately, 30% of women do report poor satisfaction with their contraceptive methods, and then there's a number of reasons that they report the dissatisfaction, and that includes things like the cost, side effects. There can be a lot of myths about them. There can be religious issues, convenience, or the concern about their health or reproductive future. So it's again we need to try to ensure that women have access to methods of contraception, that we ensure that they're getting the correct information and dispelling any myths that are out there, and make sure that we're using methods that actually have beneficial effects for their health or reproductive future, and hopefully minimal side effects or risks associated with them. Because if we had an ideal world, we'd have an ideal contraceptive that would be effective, convenient, and easy to use, and would have minimal side effects and excellent tolerability. But even when things are close to being ideal methods, they can have less than ideal adherence or continuation. So one of the things that's important for us as healthcare providers is to make sure that we do quality contraceptive counseling that can improve the compliance. Because there is no perfect method of contraception, but we need to work with the individual to determine what the best user method fit is. If we look at the different methods of contraception and the discontinuation rates at 1 year, we see that condoms had the highest discontinuation 1 year with 47%, followed by DMPA at 44%. The pills around 32%, IUD between 20 and 22%, and implants at 16%. So the question is, how can we change these discontinuation rates? How can we make this so that patients are more likely to stick with their method of contraception and hence reduce their risk of unintended pregnancy? Because when women specifically consider an oral contraceptive pill, what happens? Well, we know that 42% of them will discontinue it without speaking to anyone. They'll just stop doing it. And that when they do that, they may select another contraceptive method that can be less effective, or some will not choose another contraceptive method at all. And what's the implications of this? Again, the implication of this is the risk of unintended pregnancy. So showing what actually they do switch to within 3 months of stopping an oral contraceptive pill, you can see that 27% here in red, 27% actually don't use any other method, and with this other, this would include less effective methods of contraception. And the most commonly cited reasons for discontinuing it are side effects, 37%. So how can we try to limit the side effects or the undesirable side effects that they have of it, or other concerns that they have with respect to their reproductive health and health overall? So we know that higher continuation rates are associated with the availability of the patient's methods of choice, that access to follow-up care to discuss ongoing concerns is important, and that if they have information about the non-contraceptive benefits, they have higher continuation rates. So for example, adolescents with severe dysmenorrhea who had decreased cramping or flow with the birth control pill were 8 times more likely to be consistent pill users, meaning that they miss less than 3 pills per month, than other users. And a lot of it is about managing expectations. So making sure they know ahead of time, well, what are potential side effects, either significant ones or nuisance side effects that may improve with time, what are the benefits, and what sort of risks are associated with their contraceptive method of choice. So specifically, if we're talking about an oral contraceptive pill, again, it's really important that we dispel a lot of the myths and misperceptions that are out there about the oral contraceptive pill, because a lot of women actually won't even fill that prescription when you give it to them. So you need to make sure ahead of time that you've kind of met these head on. Really exploit the non-contraceptive benefits. Better to choose a quick start method of initiation rather than waiting for the next period, because that would improve compliance. Counsel them realistically about the side effects that they may have, give clear instructions including what to do in the event of a missed pill, and use motivational interviewing techniques where patients need to reflect on, well, what are my reasons for using a method of contraception and using that method of contraception consistently. This is the results of a study that we did looking at Canadian women's beliefs about oral contraceptive pills, and you can see that there are a lot of kind of either they're not aware of some of the benefits. For example, although many of them are aware that it helps to regulate periods, fewer are aware of the fact that it may decrease menstrual bleeding, dysmenorrhea, or acne. However, there are significant concerns that it can cause weight gain and that they should take a break from it if they need to, and that may also be associated with infertility and birth defects. So there are those myths that are out there that our own Canadian women are expressing. So the myths, weight gain, cancer, effect on future fertility, they have to take a periodic OC holiday, you can't take it over the age of 35. Again, we need to dispel all those. And what's the evidence for that? Well, we know that weight gain, that's not a trivial concern, and a lot of adolescents, that's a major fear that leads to discontinuation. If you, in one study where they looked at suburban teens, 85% said weight gain was a very important concern for them. And in adult women, it's a common reason for self-initiated discontinuation. And you've all seen it in your practice as well, I'm sure. But based on the best available evidence from randomized placebo-controlled trials and the Cochrane review, it shows that there's no large effect of combined hormonal contraception on weight. The other concern that a lot of our patients will have is the potential risk that there's an increased risk of cancer in patients that are using the oral contraceptive pill. And again, based on the best available evidence, that doesn't seem to be the case. Dr. Vesey from the UK published a very large cohort study of women who'd been followed for several years, many of them who'd been on 50 microgram pills as opposed to our lower dose pills. And what they found was that there was no significant difference or no significant increase really in the risk of breast cancer, and basically it hovered around 1. There were significant decreases in the rate of uterine cancer and ovarian cancer. And cervical cancer, as we know, there appear to be an increased risk, but the other confounding issue there is the issue of HPV. So at worst case scenario, studies have shown that there may be a very slight increased risk, but the majority have shown there really does not appear to be an increased risk in the risk of breast cancer, which I think is reassuring for our patients. Also a reminder of the fact that there are a lot of non-contraceptive uses for hormonal contraception, and this is an opinion published in ACOG, authored by our own Dr. Reed, who elaborated on many of the potential non-contraceptive benefits of oral contraception. It is important that we are aware of the adverse effects of COCs and look for ways in which we can decrease those adverse effects that patients can have, and try to see, is there a pill that might be better for them that may be associated with fewer of these side effects. So some of the more what are felt to be estrogen-mediated side effects, such as nausea, breast tenderness, and headache, they're usually mild and transient and resolve within a few months of starting the pill. Less common things are things like decreased libido, unscheduled bleeding, and mood changes. And then there are the rare side effects like VTE, MI, and stroke. But what's really interesting is that most women using pills don't report any adverse effects. And the other thing that's really interesting is that when you look at studies where they've been on a pill and they've been on a placebo when it was being used for reasons other than contraception, because obviously that's not really ethical to put them on placebo if they're using it for contraception. But what they found was that they pretty much had the same incidence of these nuisance side effects in the placebo group versus the oral contraceptive pill group, which is quite interesting. So the majority of women will in fact report no adverse effects. Again, this is courtesy of Dr. Reed, just putting the risk of VTE into context. Baseline risk of VTE in the general population is 4 per 10,000 women years. If we have someone on oral contraceptive pill, that risk increases to 9 to 10 per 10,000 women years, but it's still lower than the risk of VTE in pregnancy. And as far as when to start, we often talk about Sunday starts and day 1 starts, but probably the better option is a quick start method where they start it immediately. It doesn't matter where they are in their cycle or the time of the month. And what's been shown in studies is that compliance at 3 months is better, so they're more likely to still be on it in 3 months when they come back to see you. And there's no increased risk of side effects, for example, unscheduled bleeding. The main thing with this method of initiation is using backup contraception or abstinence for the first 7 days. And of course, reminding women what to do if they miss their pill. And this is a mobile version of the app available through the SOGC website. It's called Stay on Schedule, or SOS. And it's very helpful in reminding patients what to do if they miss a pill, because it does take some time with counseling, and it might be a lot easier if they have it handy for them as opposed to trying to remember what you said in the office. And the one thing that we want to do too when we're providing effective contraception is kind of break down those medical barriers that are there. And these are things that we put up as healthcare providers. So we often we think we're doing what's in our patient's best interest, and we want to do what's in our patient's best interest, but sometimes we put up these medical barriers to accessing contraception, and these include things like delaying initiation or applying inappropriate contraindications. And sometimes there's also regulatory or financial barriers that are there in place. So we want to try to avoid these medical barriers to contraception and remove those. For example, are any of these reasons to delay the initiation of oral contraceptives? And the answer is no. You don't need to do a pregnancy test first. You don't need to do a pelvic exam, a pap smear, STI screening. None of those things need to be due. But sometimes we're still trying to do those before we'll let someone start an oral contraceptive pill. And again, just the idea of using a quick start method rather than waiting and doing all those things, just start right away. The other thing is also sometimes we're applying inappropriate eligibility criteria to them, and this is a great guide for clinicians. Both the WHO and the CDC have published medical eligibility criteria for contraceptive use. So for example, you know, the oral contraceptive pill, you can use it in someone who has lupus, provided that they are not positive for antiphospholipid antibodies. You can use it in someone who's diabetic, provided that they don't have significant uncontrolled hypertension associated with that. So we need to stop applying contraindications to a method that may not actually be true. And once again, there is an app. There's an app for that. The CDC has this. So again, you can quickly pull that out in your clinic if you're not sure you wanted to review something. And then the guides because the question is often was, well, if I'm going to use a pill, what pill do I use? And the guides for the use of combined oral contraceptives, in the Canadian Contraception Consensus, we say basically that the preparation of choice is the one that provides effective contraception, good cycle control, and the least side effects for that individual, and that a low-dose preparation is preferred. And that was in 2004 when we had a 50 microgram pill, but again, 35 micrograms or less it was preferred. The FDA actually says for any particular estrogen or progestin combinations, the recommended dosage regimen is that which contains the least amount of estrogen and progestin that's compatible with a low pregnancy rate and the medical needs of the individual patient. And Health Canada also says that the lowest possible dose formulation compatible with a high level of efficacy, a low incidence of side effects, and good cycle control should be prescribed. So those are kind of our guides for the use of oral contraceptives. Now, how has the oral contraceptive pill evolved with time? Because it certainly has evolved with time. This is the Time magazine cover, one in 1967. And then how has it evolved to the magazine cover in April 2010? And really, developments in the oral contraceptive pill have focused on improving tolerability and acceptability for patients while also maintaining efficacy. And certainly when it started, women had a lot of side effects associated with the oral contraceptive pill, both nuisance side effects as well as more significant or serious risks associated with it. So the main development strategies have been to reduce the dose of ethinyl estradiol. There's also been the introduction of new progestins and the introduction of new estrogens. And other development strategies have included reducing the hormone-free interval from 7 days, using extended or continuous regimens, and hormone phasing is another thing that's been utilized. So one of the really big changes we've seen is, as I said, that reduction in the amount of estrogen in oral contraceptive pills. If we look back in 1960, the dose was up to 150 micrograms of estrogen, and that came down pretty quickly to 50, followed by 35, then 25 and 20, and now we're down to where we have 10 microgram oral contraceptive pills available. So the different approach can include less estrogen, because the less estrogen can decrease the risk of estrogen-related adverse events. Decreasing the hormone-free interval, because that can decrease the chances of follicular development and maybe help to improve some of the other side effects associated with oral contraceptive pills. And using estrogen-only pills in what was formerly the hormone-free interval, because that may actually have some beneficial effects as well, both for efficacy and side effects. So why the lower dose of estrogen? Again, I think we're all kind of familiar with the side effects it can have. It certainly can decrease the incidence of estrogen-related side effects, or presumably estrogen-related side effects, such as bloating, breast tenderness, and nausea. There's also concern about estrogen-related safety issues, which is the real reason behind the impetus to change this early on. That includes things like breast cancer, cerebrovascular complications, VTE rates, and myocardial infarction. And recall that estrogen and progestin act synergistically. So a lot of people are worried about, well, if I decrease the estrogen dose, then it's not going to work. And I mean, we do have progestin-only methods out there. And the primary mechanism of action of an oral contraception is actually mediated by the progestin component, not the estrogen component. So yes, they work synergistically, but it's mainly the progestin component that has the contraceptive effect. So lower doses of estrogen can be equally effective. So why would we go to a shorter hormone-free interval? Well, what's interesting here is that with a shorter hormone-free interval, you actually decrease the chance of follicular development. So theoretically, you think, well, could that potentially mean that it's a bit more effective because I decrease the risk of escape ovulation? The other thing is it can also decrease the length of withdrawal bleeding, which may be a beneficial side effect for some women, and it may decrease the intensity of the withdrawal bleeding, and these in fact have been shown in clinical studies to be true. Shortening the hormone-free interval does improve follicular suppression. So this illustrates that a shorter hormone-free interval results in greater follicular suppression. So I'll just get this here. The follicles being here. So you can see that there's greater follicular suppression with 4 days as opposed to 7 days. With a shortened hormone-free interval, the period of FSH accumulation is truncated, so follicular development is suppressed, and the fluctuation in the estrogen levels are avoided as well. So here, as you can see, these are the endogenous estrogen levels, whereas here, you're avoiding the fluctuations and the increases in the estrogen that you can see with a 7-day hormone-free interval. And this basically illustrates something similar. This is from a different study, that the increase in gonadotropins as well as estradiol are reduced with a 3-day hormone-free interval. So this being the 7-day hormone-free interval, this being the 3 or 4-day hormone-free interval, and you can see that your FSH levels and your LH levels are truncated, and that your estradiol levels don't go up as high, and you don't have as much fluctuations. And that may have implications as far as side effect profiles. So for women who have hormone-mediated side effects during the hormone-free interval. And it may also have implications for bleeding and unscheduled bleeding, because there may be less unscheduled bleeding with the lower estradiol levels earlier on. So the hormone-free interval, the regimens with altered or eliminated hormone-free intervals provide greater ovarian suppression, but the question is, okay, yeah, that may be the case, but what does that actually have implications for practice? Does that actually mean that it's more effective? And up until recently, we really didn't have any evidence telling us that this was more effective as a method of contraception as far as the actual effectiveness or efficacy. But what's been published recently is that unintended pregnancies are actually reduced with 24/4 regimens compared to 21/7 regimens. So we actually do have that data showing that now. And also with extended regimens, we find that with 84/7 regimens, the pregnancy rates are significantly lower compared to either 21/7 or a 24/4. So 21/7 doesn't appear to be the ideal regimen to be using, dosing regimen. And lastly, why would we consider having estrogen-only days? Why do you really need that? And again, it comes down partly to the fact that there's greater pituitary ovarian suppression. So that can prevent the increase in FSH, which prevents follicular development, which can prevent endogenous estradiol production, meaning there's a reduction in the risk of ovulation and a reduction in the hormone withdrawal symptoms. What's also interesting is it may reduce menstrual bleeding, and it may be, again, more forgiving in the event of missed pills, but that's theoretical at this time. I don't think that we have any evidence to support that yet. So just in summary to my part of the morning session, globally, oral contraceptives are used by 8.8% of contraceptive users and are one of the most commonly used methods of contraception in Canada. It's really important that we determine the best user method fit when we're discussing contraceptive options and adequately counsel pill users in order to promote adherence. We need to break down the medical barriers to pill use, including delaying initiation and applying inappropriate contraindications. And as clinicians, we do have good guides to help guide us in that from the CDC and the WHO. And lastly, pills have evolved significantly. We've got decreasing ethinyl estradiol levels, decreasing hormone-free intervals, new progestins, and having this additional bit of ethinyl estradiol. And that's been in an effort to improve the tolerability, decrease the incidence of side effects, decrease the risks associated with it, and ultimately improve adherence while maintaining effectiveness. And women have a choice of pills to address their needs and concerns, and we want to ensure that that continues. So I thank you very much for your attention, and at this point, I believe I'll turn it over to Dr. Archer.
Thank you very much, Dr. Black, and good morning. I am very sorry and apologetic that I can't be with you, but I hope that this presentation will give you some insight into the combination oral contraceptive efficacy and safety of lower doses. My disclosures are not on an image, but I am a consultant to a variety of pharmaceutical companies, including AbbVie, Agile, Bayer Healthcare, Chemo, Endoceutics, Merck, Pfizer, Shionogi, and Therapeutics MD. I have currently active clinical research grants from AbbVie, Agile, Bayer Healthcare, Endoceutics, and Therapeutics MD, and I'm on the Speakers Bureau for Merck, Pfizer, and Shionogi. With that as a background, let me give you the next slide, which are the learning objectives. I'd like to work with you to identify the incidence of ovulation that you see with combination oral contraceptives and oral progestins. That's highly variable related to the dose duration of the method. Secondly, I'm going to try and show you that ovulation inhibition per se with combination oral contraceptives does not contribute to the clinical contraceptive efficacy. Briefly, I'll indicate the efficacy of low-dose ethinyl estradiol 10 microgram, norethindrone 1 milligram combination oral contraceptive, with the understanding that this is the lowest ethinyl estradiol dose on the market at the present time, and that safety may well be related to the dose of the estrogen and not specifically to the dose of the progestin. I'd like to identify risk factors for compliance with combination oral contraceptives, which I believe contributes to the overall pregnancy rate or Pearl Index, and briefly discuss with you the adverse vascular events that occur with ethinyl estradiol and norethindrone in comparison to other combined oral contraceptives. In the next slide, let me just give you an overview of what a combination oral contraceptive is. This is somewhat a trite statement since many of you know it contains estrogen and a progestin, but many of our younger people don't really know what the estrogen is or the progestin is. But ethinyl estradiol, or estradiol itself, is now the estrogen in a combination oral contraceptive, and as you heard in the previous presentation, estrogen really reduces follicle-stimulating hormone levels and inhibits follicular growth or development. Having said that, the lower the dose of the estrogen, the increased possibility, and let me stress possibility, exists for follicular development. And I think follicular development without ovulation does occur in women using lower doses of oral contraceptives, and particularly progestin-only contraceptives with no estrogen in them at all. The combination oral contraceptive also contains an orally active progestational agent, or progestin, and the principal mechanism of action of the contraceptive effect of an orally active hormonal method is the impact of the progestin on inhibiting the luteinizing hormone surge, and therefore it results in anovulation. So one can have a follicular development with lower doses of estrogen or with no estrogen, but with the inhibition of the LH surge, ovulation does not take place, and that is the progestational activity. In the next slide, let me show you interactively. We start with estradiol, and in the next slide, we develop ethinyl estradiol in the next slide by adding an ethinyl molecule at the 17th position. The difference between these two compounds is that now ethinyl estradiol is orally active at a much lower dose. So we are talking 50 micrograms, 30, 20, or 10. Estradiol, we're talking 3 to 4 milligrams. So there is a difference here of a factor of on the order of almost 100 times. The next slide shows you mestranol, and the slide after that next slide shows the methyl group at the 3 position. And this compound has no longer been actively used in many oral contraceptives. The next image gives you the chemical derivatives of testosterone. Testosterone was the beginning steroid that was used, and what occurred in the next two slides is that they added the ethinyl molecule at 17, and that created ethisterone, and then they took out the 19 angular methyl group to create a norethindrone molecule, and this particular molecule was found to be orally active and acted like a progestational agent. So it has a progesterone agonistic effect on inhibiting the LH surge. Given initially, it can, in low doses, stimulate a surge, but in the pharmacologic doses that we use, it does not. And then in the next slide, Norgestrel, and the next slide is nothing more than adding an ethyl group to the 18 position compared to norethindrone. Both are orally active, have progestational activities in the body, and as such, inhibit ovulation and the principal mechanism of action. So the next slide shows the endocrine changes during the menstrual cycle. What you would see, instead of the rising estradiol level in the very top panel in the red, the ethinyl estradiol, by inhibiting follicular development, inhibits estradiol production. On the subsequent panel below that, the LH surge is blocked by the administration of progestin, and the important aspect is that you have to give the progestin at least 24 hours or longer before the LH surge. Although the menstrual cycle is stylized to 28 days, there is a high level of variability in the interval from the onset of a menstrual period to the ovulation, whereas from ovulation to the next menstrual period is a more consistent 14 days. Therefore, what we have used and opted for in combination oral contraceptives, in order to be sure we don't miss anything, is we do start the oral contraceptive in the beginning of the cycle during menstruation, or even on a Sunday start within the first 7 days of menstruation, in order to have sufficient hormone on board in order to inhibit the LH surge. In the next slide, we're talking about typical versus perfect use based on Robert Hatcher or James Trussell's data points that tell you the difference between the typical use of a product versus perfect use. On the extreme left-hand side is the combination oral contraceptive pill. The perfect use has a Pearl index, that is the number of pregnancies in the first year, of somewhat below 1, or 0.3 in this particular graphic. And you can see with other forms of combination contraceptives, transdermal and vaginal rings, perfect use is usually 1 or less pregnancies per 100 women per year. However, in the typical use, it is 8% or 8 pregnancies per 100 women per 1 year of use. And now Dr. Trussell is arguing that it could be as high as 9% pregnancy rate. So what creates this discrepancy? Is it due to something that we eat? Is it due to our body weight? And what exactly is the cause? And if you contrast this discrepancy between combination oral contraceptives on the left with the 3-month injectable, the copper IUD, and an implant, one can see that when you remove the motivation, the need to take the pill on a regular basis every day, to apply the transdermal patch on a weekly basis, or to be sure the vaginal ring is inserted and removed at the appropriate time, one now sees that there is less of a discrepancy between typical and perfect use with methods that remove the motivation from the consumer. And my hypothesis in the presentation will stress the fact and show you the information that the probable cause of increasing pregnancy rates with combination oral contraceptive use is consumer compliance or motivation to take the pill. In the next image, we are now calling this discrepancy the Pearl Index creep. On the left-hand side of this slide is the 10 microgram ethinyl estradiol 1 milligram norethindrone product, and it has a Pearl Index of 2.9. In contrast to the higher dose ethinyl estradiol products shown across the bottom in dark blue with 30, 20, 30, or 35 micrograms of ethinyl estradiol, those Pearl indices in the last 20 years were all below 1. However, where these products have been used as active comparators in more recent clinical trials since 1999, one can see in the lighter blue that the new Pearl Index, using the same formulation, the same concentration of the estrogen and the progestin, has now risen to be somewhere on the order of 0.5 on the far right, to 2 in the second bar from the right, to 3.6 in the third bar from the right, and around 2 in the bar to the left, the second bar from the left. And the concern is, why are these changes taking place? One of the issues could well be the fact that in the past, women were seeking clinical trials where they wanted a contraceptive because they needed a contraceptive. It was inexpensive, and therefore it was beneficial to both the pharmaceutical company investigating the product as well as the consumer. Alternatively, it may also have to do with the FDA changing its guidance. In the past, every woman that was in a clinical trial for combination oral contraceptives was thought to be taking the combination oral contraceptive regularly and was assumed to be having frequent sexual intercourse during the clinical trial. In reality, there are times when couples do not have intercourse in a month, and those cycles are now being identified and excluded from the Pearl Index or pregnancy computation. There are times when emergency contraception is used if the individual thinks that she has not been taking her oral contraceptive reliably, and if you capture that, that cycle is removed. And there are other parameters that are influencing the overall activity rate, and most importantly, I believe these new data suggest a difference in the mental focus of the consumer. No longer was the consumer interested in requiring contraception. Now the consumer is interested in coming in and being paid for her time in a clinical contraceptive trial. The next image shows you the lower dose 10 microgram ethinyl estradiol with norethindrone acetate 1 milligram given from days 1 to 24 of the cycle, followed by 2 days of 10 microgram only. This is a extended method with a bridging low-dose estrogen, and then 2 days of placebo. The Pearl Index in this group of women between 18 to 35 years of age, the women with the most fertility or fecundability, is 2.92, a modest range of 95% confidence interval from 1.94 to 4.21. 2.92 then is on the higher end of what has been approved as the efficacious oral contraceptive. And a debate that raged 4 to 5 years ago is, what is an acceptable Pearl Index for any contraceptive? If one assumes that 100 women having unprotected intercourse for 1 year have an overall pregnancy rate of 80 per 100 or a Pearl Index of 80, then any method that reduces that pregnancy rate below a certain number should be considered efficacious. However, in contrast to other combination oral contraceptives, one might believe that this efficacy is less than what you'd see with a higher dose estrogen method. What I would like to point out to you in the subsequent slides that this is probably a fallacious thinking, that the estrogen dose, as I mentioned before, is inhibiting the FSH level in follicular maturation, whereas it is the progestin that is the active ingredient in a contraceptive. In the next slide, what do we use in judging contraception parameters and efficacy are the pharmacokinetics. Is it absorbed well? What is the concentration maximum? How long does it take to get to that, the Tmax? What is the distribution, its overall metabolism and excretion? But for most of us, the easiest thing are what is the concentration maximum, Cmax, and what does the absorption kinetics look like? In the next slide, these data from Westhoff show you the absorption and distribution of ethinyl estradiol and levonorgestrel in normal weight women and obese women. The very top panel A shows you the mean ethinyl estradiol levels over 24 hours. And as you can see, the obese women in the dashed line have a lower C maximum in this level. However, by 24 hours at the far right, the actual serum concentration of ethinyl estradiol is the same in the women obese or normal. And therefore, 24 hours is presumed to be the trough or lowest level after absorption. The progestin activity in panel B, the levonorgestrel level, shows you that, again, the Cmax is less than what you see with in the thinner woman. But again, at 24 hours, the trough levels are similar. And the presumption is that if the trough levels are similar, then the efficacy is unchanged, even though the obesity tends to reduce the absorption kinetics. The same finding has been verified by another investigator, Dr. Edelman, showing a lag of 2 to 3 days before the oral levonorgestrel builds up to a serum level that is a consistent trough level. However, the clinical implication of that finding is not known at the present time. The next image then talks about how can we assess ovulation. So in the past, what we have used is to measure serum progesterone levels anything greater than 3 nanogram per ml on 1 or 2 evaluations in the appropriate luteal phase would be considered ovulation. The increase in serum estradiol followed by an L8 surge followed by an elevated progesterone is now classic in clinical endocrinology. Adding ultrasound evidence of follicular activity with a rising estradiol, an L8 surge, and progesterone is appropriate for clinical investigation scientifically and can be used in clinical trials. And measuring a follicle that reaches 15 millimeters and then shows collapse was also an additional assessment of ovulation. In the next slide, the argument for the criteria of ovulation is now a little bit diffuse. Can you measure ultrasound frequently enough that a follicular development that ruptures, the disappearance of the follicle or a reduction in size of 50%, is evidence of ovulation? Ovulation, then, by default, is a follicular rupture that's preceded in certain studies by an L8 surge in the preceding 24 to 48 hours and then a subsequent elevated serum progesterone level. But we are beginning to see evidence of what is known as the luteinized unruptured follicle more frequently. There is no follicular rupture. There is a blunted or no L8 surge, and it's followed by a serum progesterone that is elevated but does not reach the level of greater than 10 nanomole per liter that we assume would be evidence of classic ovulation. In the next slide, I give you a photograph, a ultrasound image, two-dimensional for follicular diameter. When you measure twice a week or 3 times a week in some studies, follicle development in women on combination oral contraceptives, you can certainly see follicles similar to this developing. And what we have been doing is using two-dimensional ultrasound in 3 dimensions to obtain a mean or average. In panel A, we're measuring in a frontal view the height and the width of the follicle. In panel B, we're measuring in the sagittal view the largest diameter that we can find. And then we average those things and say this is the mean or average follicular dimension. In the next slide, in 1993, Hoogland and Scooby published this scoring system. It used both the diameter of the follicle and the progesterone and estradiol levels to determine follicular activity and ovulation inhibition. A score of 1 says there's actually no follicle greater than 10 millimeters. Progesterone levels are in the normal range, not ovulatory, and estradiol levels are low normal. Potentially active, a score of 2 is a follicle greater than 10 millimeters. A non-active follicle-like structure is a follicle greater than 13 millimeters, but the estradiol level is low. An active follicle-like structure with a score of 4 is that same follicle with an increased estradiol level in the serum, suggesting that the granulosa cells are active, and a progesterone level that is anovulatory. The luteinized unruptured follicle is that follicle of greater than 13, a persistent follicle. The progesterone level is elevated, the estradiol level is elevated, and the distinction between the luteinized unruptured follicle and the ovulatory follicle becomes blurred and is based on ultrasound evidence and frequent serum progesterone sampling. So you can see there are problems within the Hoogland score, but it does allow us to overall address what's going on in the individual. In the next slide, these data is the incidence of ovulation inhibited by the progestin based on the dose, and on the right-hand side, the assessment. So currently, a progestin like desogestrel at a dose of 75 micrograms has no ovulation whatsoever using ultrasound, estradiol, LH, and progesterone. If you go down to drospirenone, 3 milligrams instead of micrograms, no ovulation, again based on current evidence, ultrasound, LH, progesterone. If you come to norethindrone only, shown at the bottom, second from the bottom, at 300 microgram, 19% ovulation based on ultrasound only, and norethindrone acetate, even older literature at 2.5 and 5 milligrams, no ovulation based on urinary pregnandiol levels, implicating no progesterone increase. The next slide indicates that there is no correlation between the Pearl index and the ovulatory rate. And you can see here the ovulatory rate can range as high as 30 at the bottom, but the Pearl index is less than 0.5. And the same thing. So you will see ovulation occurring anywhere from 3 to 7 or 8% of cycles in women on combination oral contraceptives, and yet the method is effective. And the justification for that statement is the fact that the Pearl index is low, plus the fact that other than ovulation, there are other mechanisms of action of the progestin, principally on cervical mucus. Now, see the next slide. The important issue is now compliance, and these data from Westhoff have been replicated in a trial of a transdermal estrogen that is in press at the present time. But this is an oral combination contraceptive of ethinyl, estradiol, and levonorgestrel. Pill compliance, if it was consistent, the serum levonorgestrel level was greater than 1 nanogram per ml. If that serum levonorgestrel level was less than 1 nanogram per ml on 2 or more occasions, it was inconsistent use, and if on every occasion of sampling, which was 3 to 4 times during this study, less than 1, these were non-users. So this is a comparison between normal weight and obese women, consistent users 90% in the normal weight and 72% in the obese woman. Inconsistent user, the obese individual, was 12%. Non-users for the obese was 16%. These data have been used to argue that socioeconomic activity changes the compliance. Obesity and low income and whatever other factors that are involved indicate that the compliance is less likely to be 100% or even 80 to 90%, and conceivably this result is what ends up saying that the contraceptive failure is higher now in combination oral contraceptives because of the attitude of the individual who is the participant in a clinical trial. If you look at the incidence of ovulation by compliance, if you look at consistent compliant users, 2.7% of those cycles in the normal weight individual was doing consistent compliance, but in the obese individual, the consistent in compliance had ovulation of 97%. I just can't no ovulation was 97%. Inconsistent use, the no ovulation rate for the obese woman dropped to 61%, and the inconsistent use ovulation rate in the normal weight woman rose to 38%. Again, implying that it is the inconsistent user that results in the increased incidence of ovulation and suggesting that this is a major contributor to the overall Pearl Index. In the next slide, let's talk about vascular problems. It's very difficult to get a handle on whether or not the progestin is playing a role here, but we all believe that ethinyl estradiol is the major issue in terms of thrombotic activity, and these data from Lidegaard are from the Danish national study that he has run for many years. 50 microgram ethinyl estradiol, the stroke risk is 1.2, elevated, not statistically significant. 30 to 40 microgram ethinyl estradiol with norethindrone, the increased risk of stroke is statistically significant with a doubling. Norethindrone, low dose, less than 30, has not been introduced in Denmark at the time, sufficient numbers for this study to report it. And so I have taken desogestrel to show you the difference between the 30 to 40 microgram ethinyl estradiol and the 20 microgram desogestrel products. And you can see the 30 to 40 microgram stroke risk with desogestrel is 2.2 compared to the 2.17 for norethindrone, but it drops to 1.53, dropping the dose. If one looks at a no estrogen only, norethindrone alone, you can see a not statistically significant increase, arguing that the changes in stroke are related to the potentially the dose, and by reducing the dose, you improve the outcome and reduce the risk. The next image shows you a similar finding for myocardial infarction, again with an implication that lowering the dose of the estrogen from 30 to 40 microgram to 20 microgram using desogestrel as a major comparator does reduce the relative risk, and if you take the estrogen out completely with norethindrone only at the very bottom, there is no increased risk at all. These data and other similar type of information have been strongly used to implicate the estrogen dose in the side effect of vascular impact, or arterial thrombosis, and in the next slide, venous thrombosis. And one can see again, using the same type of outline, that as you reduce the dose of ethinyl estradiol and then remove the dose of ethinyl estradiol at the very bottom with norethindrone only, there is no increased risk of venous thromboembolism, as you've heard earlier today. Therefore, it seems to me that the benefit here is to always reduce the dose of ethinyl estradiol as long as one can maintain efficacy. And by doing that, as you get to 20 and 10 micrograms of ethinyl estradiol, you're getting closer and closer to a progestin-only contraceptive using small amounts of estrogen to hopefully maintain endometrial integrity and reduce bleeding. So let's conclude that the efficacy of oral contraceptives really rely on the monitoring of ovarian function more than anything else. That the failure rates in clinical trials and in the actual typical user failure rates are due to noncompliance, not the method. The method, when used consistently and reliably, has a high level of impact on ovarian function and also on efficacy as a contraceptive. The efficacy may also be unrelated to pure ovulation inhibition. Cervical mucus is the principal second method that we think halting sperm penetration. That arterial and venous thrombotic activity is related to the estrogen dose. By reducing this estrogen dose, you are improving the outcome for the consumer by reducing the potential risks, and the progestin, at least based on the information available in current epidemiology, has a limited impact on adverse vascular events. I want to thank you very much for allowing me to give this presentation, and I appreciate the fact that I'm able to be with you at all this morning. Thank you.
Okay, we have very little time for questions because we're already running a little bit late. So if you have questions, just move fast towards the microphones, please. Anybody? No questions? Or anybody?
There is a question regarding the using this low-dose pills with PCOS, with hirsutism and elevated androgen. Would this still be effective?
Do you want me to handle that question?
Yeah. Did you heard that?
I heard the question. I'm not sure that there are currently data available indicating that the 10 microgram or 20 microgram is truly effective in altering metabolism, but both of them will inhibit follicular development, and that is probably the current source of the androgens that are elevated for the PCO patient. I would argue that by inhibiting follicular development, there should be efficacy. The very old literature does show that norethindrone itself actually increased the metabolic clearance of androgens or testosterone, and this is back in the 1970s. And so I would think that there is enough norethindrone in the Levo, the progestin component in the lower dose pills, to maintain that, although I'm not sure that there's actually pharmacokinetic data to support that statement for the more recent use of levonorgestrel or desogestrel. But overall, if you inhibit the follicle and shut down the ovary, you will improve the polycystic ovary parameter of androgen excess, and the estrogens should compete at the hair follicle level for the androgen receptor. Thank you for the question.
Thank you. There's a second question. In the view of the many ovarian cancer are now proved to be fallopian tube cancers, and when you talked about prevention of ovarian cancer, is it valid still that this pill is protect against fallopian tube cancers?
Well, my answer would be I don't know of any data that protects against fallopian tube cancer. However, the CDC data are really compelling that you can use an oral contraceptive, and if you use it for more than 1 year or 2 years, you can decrease the risk of ovarian cancer. The argument then was that you were reducing multiple ovulations that had an effect on the epithelial coating of the ovary. I can only tell you that that hypothesis may not continue to be valid in light of what we now believe is the fallopian tube origin of many of these serious cancers. But I could also say to you that the clinical evidence suggests still that using a combination oral contraceptive will reduce the risk of ovarian cancer for up to 5 to 10 years.
Thank you.
Okay, go ahead.
Thank you. Professor Ramsey from Cairo University. I just wanted to ask about that some patients come complaining of headache. Is it related to the estrogen component or the progestin component?
Dr. Black, do you want me to do that one?
Yeah, you can feel that one if you want, and I can add in at the end.
Well, one of the benefits of using a bridge strategy of low-dose estrogen on a standard 21 or 24-day pill was to reduce the incidence of what are known as menstrual migraines. And Dr. Patsy Sulak has shown that in several studies, and the argument is that the significant drop in the estrogen level was the trigger that causes the vasospasm and dilatation that is associated with migraine. I am not sure that because headache is so ubiquitous that headache incidence in progestin-only clinical trials, such as implants and injectables, are probably the same as in the placebo group and about the same level that you would see in a combination oral contraceptive clinical trial, anywhere from 8 to 15%. But I think menstrual migraines are certainly relieved by bridging with low-dose estrogen during the time of withdrawal in the standard combination oral contraceptive, and therefore I believe that estrogen is the principal component that is preventing these headaches.
Thank you.